Well, good afternoon, and thank you all for joining us this afternoon for the second in our webcast regarding global budgeting here in Maryland. I am David Chin, Distinguished Scholar at the Johns Hopkins School of Public Health and also Executive Director of our Executive Education Program for Transformation for Value-Based Healthcare. With me this afternoon are two leaders in the Maryland healthcare system. To my left is Carmela Coyle. She's President and CEO of the Maryland Hospital Association, and she was instrumental in facilitating the dialogue between state leaders and hospital leaders across the state in the implementation and negotiation of the waiver. Also, I should mention that she just posted her blog today in Health Affairs about the Maryland experience with the waiver over the first year. And to her left, we have Leslie Simmons, and she is the CEO of Carroll Hospital out in Westminster, Maryland. And she has the distinction of managing her hospital over the last 5 years under a global budget. And we were talking beforehand here in the studio, and she's got some great stories about how she's managed and managing the alignment of incentives and managing the program very successfully over these last 5 years. As a matter of fact, her positive experience under the waiver, under the global budget, is what gave confidence to Carmela and to the state leaders about going ahead with a statewide waiver. So thank you very much.
Pleasure.
Before we get started, I also want to say thanks to Carmela and her team at the Maryland Hospital Association, as well as the American Hospital Association, for collaborating with us in the creation of these webinars. As I mentioned at the beginning of these, that this is a series of 5 webinars. The first one you can see archived on our website at jhsph.edu/global budget, and that gave an overview of the global budget system in which hospitals no longer dependent upon volume for the revenue. In point of fact, they get rewarded if preventable admissions, et cetera, are kept out of the hospital. So it's a new way of thinking, turns, as Leslie had mentioned earlier, turns the ship around 180 degrees in terms of how to think. So that was the overview. Today we'll be talking about the case study. The third in the series will be coming up. We'll be focusing on how global budget might come to your neighborhood. And then the fourth one will look at global budgets and the care continuum. And then finally we'll have the federal perspective with Patrick Conway from CMS to talk about what he thinks the future from the federal perspective might be around global budgets. In terms of the format this morning, we're going to have remarks first by Carmela and then by Leslie for about 20-25 minutes, and then we're going to spend the rest of the time in Q&A, and then we'll wrap it up. So over to you, Carmela.
Great, thank you very much, and it's very much a pleasure to be here today. And you know, it's interesting, we find ourselves at a very important point in time in Maryland's global budget journey. As you referenced just yesterday, we got the final public first-year results of our 5-year demonstration program, and I'll talk a little bit more about those in just a moment. But just a reminder for folks who may not have seen the first part of the series on global budgeting. This is a 5-year demonstration program entered into by the state of Maryland and the federal government, and it is, of course, all about the shift from volume-based payment to value-based payment. And at the core of that demonstration program are really 5 metrics. I often say you only need to know 5 things about the Maryland program. 3 financial metrics and 2 quality metrics. The 3 financial metrics, Maryland's hospitals agreed that we would limit the rate of growth in hospital spending, that is inpatient and outpatient spending, to no more than 3.58% per person each year. Second, we agreed to save the federal Medicare program $330 million over the 5-year life of the demonstration. And third, we agreed to hold our total healthcare spending trend, hospital and non-hospital, in Maryland to no more than the national trend. And on the quality front, which is really an important part of this story, we agreed to bring our readmissions rate down to the national average over the 5-year period. And we also agreed to reduce complications, hospital-acquired infections as an example, down by 30% over the life of the demonstration. And just yesterday, a paper published in the New England Journal of Medicine by officials at the Centers for Medicare and Medicaid Services, and state officials here in Maryland gave us our final results. And they're quite terrific, and quite frankly, I think surprising for everyone involved. The short version of the scorecard: we said we'd hold spending to no more than 3.58%. It came in at less than 1.5%, which was terrific. The savings, the federal government said $330 million in Medicare savings over 5 years. And in fact, they expected nothing in the first year. They knew it would take us some time to make that 180-degree shift. We saved the federal Medicare program $116 million. And in fact, not only did we not exceed the national trend in total healthcare spending in the state of Maryland actually declined.
Wow.
On readmissions, we are on track, not quite as far as we'd like to get, but we reduced readmissions faster than the rest of the nation, but we've got work still there to go. And I'm pleased to say on the 30% complication reduction over 5 years, we reduced complications by 26%. So all of that publicly announced yesterday. We are very pleased. But what's interesting about all of that is in this agreement between the state and the federal government, and those 5 metrics I just talked about, they really only define what it was that we set out to do. There really wasn't much in the agreement that talked about how we were to achieve those objectives and those outcomes. And I think that's really the important topic for today, and you'll hear more from Leslie in just a moment. How is it that hospitals transform the way in which they're delivering care? We're still at the early stages of that, but a lot of change has occurred. And just some introductory remarks perhaps on the how. Obviously, moving Maryland's hospitals to global budgets was critical. That was not in the agreement between the state of Maryland and the federal government. That was something we in Maryland, working with our state rate setting commission, decided to do, understanding that if we were able to move hospitals to global budgets, we'd have a better chance at making these metrics. Of course, the big surprise there, we knew we would see hospitals migrating toward global budgets, and in fact, we now have every hospital in the state, except for the brand new one that just opened, on global budgets, and they moved there within 6 months. So a pretty rapid change. The second how in all of this is all about a change in the way in which not just hospitals are paid for care, but how they deliver care. And to Leslie's analogy of a 180-degree turn, it's like taking that big barge in the mouth of a very narrow river and trying to pull it in the opposite direction. And you'll hear from Leslie, but hospital leaders across the state really did an amazing job in moving, literally in about 6 months' time, from a fee-for-service based per patient mechanism of paying for hospital care to this global budget world where they get one amount for the entire year to treat everyone who comes into their organizations through their doors. And that is a completely different way of thinking about how we do things. Of course, the most important change that means, it's a focus on cost management and cost reduction. It's a focus on reducing unnecessary use of hospital inpatient services where possible. It is all about avoidable utilization, not just in the hospital, but out in the community as well. And what we have seen is a tremendous turnaround, a tremendous investment in community-based infrastructure, so that when a patient comes to our hospitals, and they stay on average 3.5 days, and as we discharge that patient, we're actually creating a clear care pathway for that patient back into the community. And that means making certain that our community providers are strong and vibrant and well connected to what's going on in the hospital, so that we can prevent that patient from being readmitted to the hospital unnecessarily. And I know we'll hear in just a moment from Leslie some very specific examples of what they have been able to do at Carroll Hospital. Just one more reminder of the situation in Maryland. We had 10 hospitals who started experimenting with global budgets some 4 or 5 years ago. the rest of the hospital in Maryland coming online in the last calendar year. So tremendous change for us. Very much in the foothills. This is early for us. We have still that mountain to climb, but we're pretty pleased, as is the state, as is the federal government, with the first year results.
Those are terrific results. And I forgot to mention that if you have questions, and I think it'll come up on the screen, you can just send them to globalbudget@jhu.edu, and those questions will come in on the iPad here, and then when we go to the Q&A, be able to triage those questions and direct them to Carmela and to Leslie. So it's globalbudget@jhu.edu. So now we'll turn over to Leslie, and you've got some great stories about the how.
All right. Well, I'll tell you, we started our journey into total patient revenue, is what it was called. We had an opportunity by the cost-setting agency in Maryland, the HSCRC, to invite us to look at this type of reimbursement. And at the time, it was very new for us. We were in that fee-for-service world. And so it was just an education process to our board of directors and to the physicians and the clinical staff about what this program was all about. So literally, we accepted the challenge and went into this pilot program and began the challenge to educate all of us on how were we going to do this? How are we going to go from fee for service to really taking care of our patient from a value perspective, and really understanding that it wasn't going to be enough anymore just to be a great hospital when patients were very sick. We had to learn to break down the walls of the hospital, reach out into the community, work with all the providers, and focus on chronic disease management, on overall health and well-being, focus on wellness, so very different skill sets for the acute care hospital. So one of the things that we experienced right away was our physicians weren't compensated based on value per se.
Right.
They are still in that fee-for-service world and remain there today. So it's a bit confusing for them. And there was a lot of grassroots efforts from the leadership team to really educate our physicians and our community what total patient revenue was all about. And when I spoke about literally changing, the direction of the ship in the water, that's really what it felt like, because we needed to move quickly and in an organized fashion, and we needed to get everybody involved in that. So we began looking for mechanisms to align with our physicians, and it became evident that one of the easy ways to do that would be in the way we cared for our employees. So we aligned our physicians with our employee benefit program. And so if they signed up for that, we created something called a physician hospital organization. If they became a part of that, then we sent our associates to care with those physicians, and they were rewarded with a bit higher reimbursement as long as they were able to sign up to manage the health of our employees. So we started the initiative mainly focused with our employees because we knew that was a very controllable group. And we have about 2,000 associates at Carroll Hospital, and so we started doing health risk assessments and teaching the physicians how to focus on them and reduce them. And then very quickly that served as a great platform to roll that out to the rest of the community, because we began to see some alignment with our physicians. So we looked at our data and started understanding our readmission rates, started understanding who were those people in our emergency department that were utilizing it to a very high degree. There were some really surprising discoveries when looking at that data. And we began to learn that it was, as I said earlier, very important for us to break down the walls of the hospital and sit with our other community providers. We have about 135 other agencies in our community that provide some type of assistance or care. And so we got a seat at the table and said, how can we better make good connections for our patients once they're discharged? It used to be we'd take amazing care of you when you were in the hospital, and then we'd do these great discharge instructions, pack you up and send you on your way and hope for the best. And then if you needed to be readmitted, well, we were going to be here to take care of you. Well, now when a person is readmitted to our organization, it's almost a failure of the system. What did we neglect to do for that patient that they had to come back so quickly? So we really began to put a lot of different programs and services in place to try to manage that entire process. Things like care navigators in the emergency department 24/7. A big one is a pharmacist to help with meds management. You know, our patients these days are having on average of 10 or 12 medications, and their ability to understand how to manage them, even to afford to get them filled and take them properly, was a challenge. So putting pharmacists in our emergency department, putting pharmacists up on the patient care units to be able to do education at discharge, and then really making those connections for patients, looking at transportation issues, looking at their ability to eat the proper foods and understand that, just getting an appointment, a follow-up appointment with their primary care physician. You know, oftentimes we were learning that people were visiting our emergency department repeatedly because they couldn't make an appointment with a primary care physician in a timely way. So that was another way we were able to partner with our physicians to say, you know what, the emergency department is a very expensive location for care. So how about we get those patients to you in your office in a much more expedient way? We learned from the physicians, well, that's great, we're happy to take the patients, but your requirements of what we need to do for patients has become significant. Help us with chronic disease management. And that's when we started really developing chronic disease management coaches that could go into our large community primary care practices to say, let me navigate those patients for you. Let me provide that higher level of education and support that's very time consuming for you, but can help the patient and the whole system. So we began to see
So I've heard that right, just pardon the interruption. So
No.
you actually sent a coach into a practice.
Correct.
So, and they physically were in there
Physically in the practice,
Like for
seeing
40
the
hours
most
a week?
high-risk patients.
and like
Right.
have office hours and this kind of stuff, or just,
Indeed.
wow.
Right when the physician has the office hours,
Uh-huh.
and you know, many times we're able to identify those high-risk patients pretty early on, especially those that need a lot of additional service. So it's almost like the navigator would be able to know, the coach would be able to know Mrs. Jones, who's high risk, is coming in. So I'm going to call her ahead of time and tell her what we're going to do, you know, and then really so Mrs. Jones would see the physician and then go see the coach and make sure everything is taken care of. So we've also learned in these past several years that it's not enough just to provide that service at the hospital. You have to reach out in the community. You know, it's true, we do have the patient as a captive audience when they're in the hospital, but once they're discharged, we were losing touch with them. You know, so that we had to find mechanisms to be able to stay in touch. Sometimes patients are questionable about that level of intervention with them. So we help them understand this is good for you. This prevents that readmission. This prevents you from having to come to the emergency department. These are free services that we can provide for you to help you be successful and manage your disease. So, you know, that has been a very important component, but then there's also a whole separate initiative around health risk assessment for the community to try to help them identify triggers or risk factors and help them to learn how to live healthier so they don't develop chronic disease. So I think that's another thing that's been a challenge for hospitals, because you're on the journey to try to reduce your readmissions and reduce your high utilizers in the emergency department, but that's only one aspect of population health and really trying to make a difference on, in the overall health of your population. So you can't just look at one thing. You got to have a foot pretty much in a lot of areas. So, you know, we have seen some initial success. We've done some exciting things for behavioral health in our emergency department by working with the police force and having them learn how to make non-clinical assessments on people that might be arrested for substance abuse issues or disturbance issues, and they're able to make early assessments to get a patient right to a crisis management bed and not into the emergency department, which may not be the best thing for them at the time. So that's a really good example of how we've begun to work with the community and maybe non-traditional providers in the community to make a difference, you know. So again, that's been very successful. So here we are, we're in our 5th year. We're really excited to be able to help our other colleagues across the state to be able to learn lessons learned from us, because it's hasn't been easy. You know, we've implemented so many different kinds of programs, and oftentimes we're not sure which one of those initiatives are making the key difference, you know. So one of the things we're experiencing now is we had a lot of early success where we were able to drive down readmissions, drive down some of that emergency department utilization, and actually found ourselves in a good position within the state when we compared our data. But what we're experiencing now is it's hard to get that next level improvement. You know, so you're getting early on, you're getting those patients that are really excited to be able to have you help them. You're partnering with your physicians, but that stuff has been taken care of. Now we're looking for sustainability and how do you get that next level of improvement. And that's where I think things are a bit more challenging. We have enjoyed some exciting partnerships with our health department and our hospital by creating a medical home for the under and underinsured called Access Carroll. And that's been a phenomenal venue for us to really get people the additional connections they need in behavioral health, regular medical services, pharmaceutical, prescription drug management, and dental. Dental is another big need in our community. So it's been exciting to discover those partnerships along the way. And I'd have to say that was one of our biggest lessons learned early on. We can't do this by ourselves. You know, we really have to reach outside the walls of the hospital and understand who those partners could be. So it's been a great journey. We continue to learn every day. I will say that we've also learned that the improvements tend to be one patient at a time. You know, really identifying those patients that you care for in your community that are consuming the most amount of services and helping them one patient at a time make that better plan of care that Carmela was referencing. And you know, it's been a joy to see that we can control the cost and achieve huge improvements in the quality. You know, it's a great thing. Early on, I think some of the criticism that you'll experience from your community is, are you just trying to rush me out of the hospital? And you used to admit me and now you won't. And when we focus and tell them, we also have to pay attention to the quality of the care you receive, and we're monitored and need to report data around that and your satisfaction, that helps. And now that we have data to begin to show the improvement, that adds to the credibility of what we're doing.
And if I may add, as Leslie was talking about this word partnership, imagine, we're seeing that across the entire state of Maryland. Maryland's hospitals in this first calendar year invested about $150 million